Good evening, ladies and gentlemen. I'm Stefano Rossi, and I have the pleasure to moderate this EKS hot topic session on the valgus knee. My co-moderator is Professor Sébastien Lustig from Lyon, and we have a great faculty today. We have Cécile Batalier, who's going to be the speaker, as well from Lyon, France. And we have two great challengers, Fritz Bottner from New York, USA, and Professor Jan Victor from Ghent in Belgium. If you have any question during the session, you can put them on the chat, and I will transmit them to the faculty. So I will give directly the words to Cécile for her presentation, and then we will have a great discussion. Please, Cécile, thank you very much.
Thank you, Stefano. And good evening, everybody. It's my great pleasure to participate to this hot topic, and thank you for the invitation. You can see my screen. It's okay. So we will talk about alignment strategy after total knee arthroplasty in valgus knee deformity. So as you can know, we tend to move to individualized medicine more and more, and it's the same for orthopedic surgery, and particularly for the knee arthroplasty. Why? Because we have a large variability of knee alignment for native patients, for native knee deformity. And slowly, we tend to move to a mechanical alignment, to a personalized alignment, to do personalized surgery. And we have several kinds of personalized alignment. We have kinematic, restrictive kinematic, reverse kinematic, functional, and all these kind of alignment tend to improve the functional outcomes of our patients, restoring their native knee deformity. And we have also several kind of classification trying to improve the description of the knee deformity. For example, the CIPA classification describe the joint line obliquity and the knee alignment, and we assess this our knee with this CIPA classification in this study, for example, in more than 1,000 of total knee arthroplasty. With mainly preoperative varus knee deformity. And when we assess the functional outcomes for this population, we found that when we restore the joint line obliquity, the native joint line obliquity, we decrease the pain after the total knee arthroplasty. So we improve the functional outcomes when we try to restore the knee deformity. Same for the functional alignment. It's an alignment described in 2020 by a team of great surgeons, and they describe an alignment take account of the three space, the three plane of space. So the coronal, the sagittal, and the axial plan. And when we assess the functional outcomes with this kind of personalized alignment, we found a better forgotten joint score with the functional alignment compared to a mechanical alignment. And it's we have more and more studies in the literature describing improvement of outcomes with a personalized alignment. But it's for preoperative varus knee deformity most of the time. And the question is, for this kind of patients, this lady, she had a native valgus knee deformity, a bilateral valgus knee deformity. What is your strategy when you will do a total knee arthroplasty? Do you want this kind of X-ray with a personalized alignment, keeping a valgus knee deformity? So it's our aim to assess the impact of postoperative knee alignment on the functional outcome and on the satisfaction of the patient in valgus knee deformity. Which alignments in valgus knee to obtain the best satisfaction for our patients. So for that, we perform a retrospective case control study in a single center. We included all primary total knee arthroplasty with a valgus preoperative valgus knee deformity, so a hip knee ankle angle superior to 180, and with a PS implant. So we excluded every patient with a semi-constrained implant or hinge implant. We exclude also patients with associated procedure like osteotomy. We exclude flexion contracture superior to 5 degrees because it's more difficult to analyze the X-ray with a high flexion contracture. And we exclude, of course, patients without long leg X-ray because on the AP view, you can't analyze the deformity. So we included 460 patients, and we classified every patient in three groups of alignment preoperatively. So preoperative neutral alignment between 0 and 3 degrees of valgus, and we included 162 patients. Mid-valgus deformity between 4 and 10 degrees of valgus knee deformity, and we included 204 patients. And the last group, it's a severe valgus knee deformity with more than 10 degrees of valgus, and we included 94 patients. After, we classified also patients with the postoperative knee deformity, so patients with a varus postoperative alignment, so more than 4 degrees of varus, patients with a postoperative neutral alignment, so with between 3 degrees of varus and 3 degrees of valgus, and patients with a postoperative valgus knee alignment, so more than 4 degrees of valgus deformity. And we assess the X-ray, the KSS, the range of motion, and the satisfaction at the last follow-up. So first, for our demographic data, we didn't find a significant difference for the age, BMI, gender between all these patients. We have a mean follow-up of 68 months. So the aim, the target during the surgery was a neutral alignment. So we have mainly post-operative neutral alignments. And now we go to the results. For the mid-valgus group, so the preoperative mid-valgus group, we found the worst KSS function score was obtained when we have a post-operative valgus alignments. For the satisfaction in the same group, so preoperative mid-valgus deformity, the best satisfaction was obtained when we obtained a post-operative neutral alignment, and it was significant also. For the severe valgus group deformity preoperatively, so patients with more than 10 degrees of valgus preoperatively, the best KSS knee score was obtained when we keep post-operative valgus deformity, and this result was significant. And for the same group, for severe valgus group deformity preoperatively, we obtained the best satisfaction when we obtained at the end of the surgery a post-operative valgus alignment, and it was also significant. We assess also the impact of the degree of correction. So if we correct a little or a lot the deformity, but we didn't find an impact of this degree of correction on the functional outcomes or on the satisfaction. So in conclusion, when we have a preoperative mid-valgus knee deformity, we try to obtain a neutral knee alignment after the total knee arthroplasty. And if we have a preoperative severe valgus knee deformity, so more than 10 degrees of valgus, we try to obtain a small valgus, we try to keep a small valgus deformity after the TKA, so more than 4 degrees of valgus. But it's difficult with our study to give you a very accurate number. It's between 4 and 9 degrees of valgus. Thank you.
Thank you very much, Cécile, for this great presentation. So I will, Jan, the words and starting to challenge you and to ask you questions about this, and we may come into the conversation with some other questions. Thank you. So who's breaking the ice?
Okay, Cecile, I will start with you. Great presentation and a great study. And obviously, the problem with valgus knees is always that they don't come in really big numbers, but you have a study with rather large cohorts of patients. Still, I wonder if you would have looked not just at the overall coronal alignment, but also at CBAC 3, 6, or 9, if your outcomes would have been different. I mean, maybe the post-op slide valgus is better for the CPAC 9, but not for the CPAC 3. Is this something you looked into, or were your numbers then too small to have a powerful study?
We didn't have enough powerful for this analysis because in every group of CPAC classification, we have not enough patients to do this kind of analysis.
That's what I thought, but still I wanted to ask you.
Yeah, but probably it's better to restore also the deformity. Where is the deformity? So in the femoral side or in the tibial side?
You know, Cecile, you guys excluded a number of hinge and constrained implants. So I assume those were the extreme knees, like above 20. I think it's a tiny bit misleading if we would say knees over 10-degree deformity can be restored to valgus alignment or should be restored to valgus alignment. I think it might be good for us, you know, even with your conclusion, to make a little bit of limitation on that and say, you know, if we look at the ones that we received a constraint and a hinge, maybe these are the ones over 20, and then say, you know, between 10 and 20, that is our finding.
Yeah, I totally agree. And usually we use semi-constrained or hinge for two reasons. For very old patients, when we are quite afraid to correct a lot valgus knee deformity and to have some complications on the collateral ligament or with fracture. And the other reason, if we usually before the surgery, we do a stress X-ray. And if the patient has no correction, we can't reduce a little the valgus deformity. Usually, we try to go to a semi-constrained or hinge TK because you need to sheet with your cut and with your ligament collateral ligament to try to restore not neutral alignment, but a better alignment. So that's why we exclude these patients. They are very incorruptible, unreducible.
Okay.
Cecile, can you also talk a little bit about, whether you did do any releases in the study, or was the goal to avoid soft tissue releases?
So we do soft tissue releases in the lateral side, but we exclude Bourdin osteotomy because it was a very big technique of release, and we don't want to include this kind of patients, and because this kind of patients usually are not reducible, so it's difficult to compare this kind of patient with the other one. So we do only soft tissue release for this population.
If I can just add one comment, Fritz, maybe to challenge you the other way. Do you think if you add to this study the patients with rotating hinge or CCK, higher constraint CCK, like the LCCK or other ones, then it's difficult to draw a conclusion. That's why we decided to consider only patients with let's say non-constraint implants. It's difficult because if you put PS implants CCK rotating hinge all together, it's really hard to conclude. That was the point, I think.
Yeah, I absolutely agree with your logic, Sebastian. I think that the trouble I always have, I always look at the worst case scenario. I have a 23-degree valgus knee, and I put it in 9 degrees of valgus. And I promise you, this is not going to be a happy end in 10 years. You know, so that's where my problem comes from. Because I don't think you can leave a 23-degree valgus knee, which it usually gets there if it is constitutional. So it's not from bone wear, it's constitutional and 23 degrees of valgus, maybe with some joint line opening on the medial side. If you take that knee and you put it in 4 to 9 degrees, if you put it on the back end on 9 degrees, I don't know what's going to happen in 10 years. You know, that's my dilemma. You might be happy right now, absolutely. But I don't know what happens in 10 years with these patients. And Cecile already said, we're worried about the old patient. Everybody is going to get old. And if you leave the knee in 9 degrees of valgus, there's going to be continued stress on this MCL. Or in 7 degrees of valgus, there's going to be continuous stress. It's like the pathology. And we all know if you wait long enough on a valgus knee, they're going to start open up on the medial side. I mean, Runabout described that. I know there's some debate, and some nice videos of that. There's definitely opening on the medial side in valgus knees over time.
Cecile, if I may extend a little bit on Fritz's remarks, obviously, if you leave the knee in valgus, the patient will use some stress on his MCL. In many of the severe valgus knees, there is already a little bit of stretched MCL. So imagine a knee that was beforehand in 15 degrees of valgus, and then you leave it at 4 or 5 degrees of valgus at the end of the operation. You will still have a stretched MCL that will continue to function under a rather high stress. Is that something that concerns you?
So, when we exclude the semi-constrained implants, we exclude also the patient with insufficient MCL. So we usually, when you restore the knee alignment, the neutral knee alignment, and you have a non-efficient or less efficient MCL, you can't stay only on a PS implants. So that's why also we remove this kind of patients.
I can see that, and very, very much stretched out MCL you will pick up, but you can assume that in every severe valgus knee, the MCL will have suffered over time, even if you don't see it on the X-ray. So what's your trade-off then to put in a hinge or a CCK if you want to leave that knee on the valgus? Is that something dangerous, or can you do it safely?
No, I'm not sure it's safe if the MCL is not very efficient. So that's why also we don't exclude. Usually we have semi-constrained and hinge in the OR. So usually when we do a severe valgus knee deformity and during the surgery we see the MCL is not enough efficient, we move to a semi-constrained or hinge because of the same reason as you said. We are not confident with this kind of MCL and we don't want to take a risk of instability. And that's why we move to a more constrained implant. And
Okay.
it's quite often to move to a more constrained implant for this kind of patients because of this reason. But a patient, if the patient has a valgus knee deformity, so he walk with a valgus of 10 degrees maybe or less since 40 years, do you think the MCL is less efficient the next 10 years compared to the previous 40 years? If you decrease the native knee deformity of the patient, you keep finally the same tension of the MCL or something like that.
No, I disagree here because the knee actually wore out over time. So the cartilage wore out and sometimes the bone. And finally, the patient came to you because he or she had a problem. So you operate at the moment that the patient has a problem. So I can assume that at least something has changed to the worse.
So why we do that for the varus knee? The same principle. The patients become more and more varus, and you try to keep some varus deformity, but it's not a
Yes.
normal knee. You operate
No, you're absolutely
pathologically.
right. And this is also one of the limits of the kinematic alignment in case of a stretched out lateral ligament. The other thing is, and you bring me to a second question, the medial side of the knee is the isometric side of the knee, the stable side of the knee, and the lateral side of the knee is the more dynamically stabilized area. So you could say in the varus knee, the biceps tendon and the ITP can take over part of the function of lateral capsule and lateral ligament. However, on the medial side, you only have the ligament. You have no muscles that stabilize you.
Yeah, it's true. It's totally true. So that's why
I have to admit that I do completely agree with Jan Victor, and I didn't realize the two of us would debate you. So I think there is a couple of things I would love to say about what you said, that the minute the medial collateral ligament stretches out, you can no longer use the PS insert. I don't think that's true. I use it all the time. It might depend on the absolute deformity degree. Yes, if we get into the 20 to 25 degrees, depending on experience level, it becomes a little tricky. But there are plenty of things that have some medial opening that I'm able to correct the knee with the PS insert. I don't need a hinge or constraint for the overwhelming majority of those knees. Now, there are some that I can't balance out, and I will use a constraint, and I don't have any religious beliefs one way or the other. But if you look at every knee that has some medial opening and you look at a constraint or a hinge, I'm not sure that's necessary if you do soft tissue releases. I think the PS and the soft tissue release, by the time you take the push-it ligament, there's a little bit correction of the deformity. Then you do the releases as have been described by Ranawat. I had a paper on that. And then you can often balance the knee perfectly out. And you can move on with the PS insert.
Yeah, of course. That's why we include 46 patients. But
Cecilia, I have another question. You obviously have patients from a time frame. What was the time frame that you collected patients on?
Sorry?
Time-wise. Was it 2010 to
It's 10 years ago. Patient in 10 years ago.
They're all 10 years out? Or over a period of 10 years?
It's between 15 and 5 years ago almost. So we have a large period of inclusion because we don't have a lot of valgus patients. So we need to have a very large inclusion period. So it's not a recent patient. That's why we have a very large follow-up also.
Another question, was the valgus deformity by accident? Was the alignment target mechanical? Or was it attempted to go into valgus?
Yeah, it's one of the limitations, of course. At the beginning, the aim was to go to a neutral alignment because it's a mechanical alignment. But as we know, it's not always possible, and sometimes we have some mistake or we have some variation, and we keep the patients, every patient. So we have patients in valgus, but it was not wanted at the beginning during the surgery.
Mm-hmm. That was another question.
Later on, you try to get there. You try to aim for a little bit valgus.
I was not here during the TK, so I think the aim was to have a neutral alignment, but sometimes they keep some valgus because it's more difficult go
I
to
think Seb would like to.
Yeah, no, I can just add some comment because yeah, it was the Philippe Nere's philosophy. So we were trying to aim for straight knees, but we were trying to balance knees also. And that's interesting to see that we did the similar study with varus knees. We published in Core maybe 15 years ago. And Cécile did a huge work on valgus knees to try to see if with the same philosophy we end up with the same outcome. And I was 100% sure, like Jan or you, Fritz, that we were going to show that we should put the knee straight. I was betting everything on that. And actually the numbers and the data are showing something slightly different. So I think it's interesting to see that quite similar to the personalized way we do now for varus knees. In valgus, we have some interesting data showing that it makes sense to maintain some, residual deformity if we can actually get the knee balanced. Because we were doing releases at that time, and we were maintaining the deformity usually at the femur side, not on the tibia. Most of the tibia was straight for valgus knees. So to me, it shows that if you can get any balanced, then you can maintain a little bit of valgus deformity if you start from a significant valgus. But I agree with you, Jan. 9 degrees is probably not good, but we had to categorize, to try to analyze the data. So we had to find a threshold. But probably I would say the same for varus. If you do pure kinematic and you end up with 9 degrees of residual varus knees, probably it's not good. So I mean, it's the same way. But we don't have yeah.
You're pretty much proposing unrestricted kinematic alignment for valgus knees, because if you go up to 10 degrees,
restricted, unrestricted.
No.
Why unrestricted? Why unrestricted?
Fritz. I have you finish your comment, and then we have 2 questions coming from the audience. Okay, please. So just go on, and then I'll pose a question.
If you look at the anatomy of the distal femur in valgus knees, the average valgus deformity or lateral distal femur angle is 85 degrees. It's slightly lower in women, slightly higher in men. So 85 degrees is the average, and it ranges between 0 and 10. So if you would do that and you cut the tibia where it is in 90 degrees, which it usually is 90 degrees, you will do pretty much unrestricted kinematic alignment. I mean, I think there's a tendency to think that, because if you say you can get away with up to 9 degrees of deformity, then the feeling is if I do kinematic alignment with a little bit soft tissue release, what you're doing, I can actually get away with. And I personally completely disagree with it. If I see a patient walk with 7 degrees of valgus or 9 degrees of valgus, you can tell me what you want with satisfaction. It just looks terrible. These people with 9 degrees of valgus, they walk, their knees touch, they support their knees one knee on the other. There is nothing pretty about it. And therefore, I do think, you want to put a knee in 2 degrees of valgus, be my guest, 3 degrees. Okay, 9 degrees? I'm sorry. You're a very experienced surgeon. You can do it maybe. But everybody out there that's on the call putting knees in 7, 8 degrees of valgus, oh my God, I want to retire before they fail.
Okay.
After it's one of the limitations. Also, we don't have enough patients to know very well the good target. But main patients with a postoperative valgus deformity has 4 or 5 degrees of valgus. We have just very small number of patients with more than 5 degrees of valgus and not more than 9. And I think we have 2 patients at 9. But we didn't find for these patients worse results. So we can't say that it's a good idea to go to 9. And it's not the aim of the paper to say to go to 9. The aim is to say for mid valgus, it's better to go to neutral, and mid valgus it's less than 10 degrees of valgus. So for less than 10 degrees of valgus, we go to neutral, and for more than 10 degrees of valgus, so it's quite a lot deformity preoperatively. We try to go almost to 4 to 5, but we have some patients with more valgus, and currently they are not doing bad. So that's why we didn't give you a good target post-operatively, because we didn't find it. But we totally agree with you. 9 is probably a bad idea, and our aim is just to keep a small valgus deformity when the patient has more than 10 degrees of valgus preoperatively. So we agree with you.
It's very important to communicate those limitations, because if somebody tells me you can put a knee 4 to 9 degrees and there's no consequence, and there are 2 patients that have 9 degrees, I would say most journals would probably not allow you to publish that statement. Because you're completely underpowered to make any statement. And if you in the group 7, 8, and 9 have 15 patients, you're still underpowered to make any statement. So one has to be a tiny bit careful with the statement. Cecile, what's really funny? That if you had a knee that would be up to 10 degrees, I would tell you, okay, you want to put it in 4 degrees of valgus, it's probably okay. I wouldn't mind that as much as I mind to take a 19-degree valgus knee and put it in 7 degrees. That is for me something that I have really headaches with. And that's interesting, because I look at it the complete opposite. I still believe that Chit Ranawat was a super smart man. I had the pleasure to listen to him in conferences and stuff like this at HSS. Super smart, analytic man. And, when he tells us to put the knee in a little bit more varus to avoid the deformity recurring, then I do take that a little bit to heart, because I assume he's an experienced surgeon. Yes, they have seen much bigger deformities in the 80s and 90s than we see right now. But I don't think we should disregard his experience and his knowledge about the knee to the point where we tell the average person out there, this is okay. I don't know. I'm a little worried about that, in all honesty.
So, guys, we have a question from Matteo Libroia, who's asking, is the valgus dysfunctional respect to the varus? I think the question is why we should treat the valgus differently from the varus, and most of the answer to the question has already been given. But if you want to add some comments about this question posed by Matteo.
I think, Stefano, I gave my main arguments, being the differential function and biomechanics of the medial side versus the lateral side. I will not repeat that. Another argument, and I'm quite happy that Fritz brought that up, is aesthetically. And I agree with him. Especially women, they dislike valgus knees very much in both stops. So, Cecile, did you see something specific between the females and the males? Because obviously you have much more females in the severe valgus group than males. Is that something to look at, sex, in terms of dealing with how much you would leave?
We didn't find a difference between both, but probably it's because most of severe valgus knee are in women patients, women. Mm-hmm. So maybe we didn't have enough male patients with severe valgus knee deformity.
The other question I would like to ask you is, I'm referring now to Sepp. He mentioned the work of Philippe Neret, and a long time ago, I tried to do the same. We all tried to put these knees into a perfect mechanical straight alignment, but because of the constitutional valgus configuration of these patients, and specifically on the femur, some valgus bowing, sometimes on the tibia, some valgus bowing, even if you aimed at a straight knee, I've seen a number of my patients ending up in a little valgus. So it might not be such a bad idea to try to leave them in neutral and then see that you're ending up in 3 degrees of valgus. Aren't you scared, or aren't you concerned that when you work with traditional instruments, traditional ancillary, and you aim at a little valgus, you will end up with severe valgus, and in line with that question, do you need robotics or navigation in order to try to achieve the goals that you set forth?
Yes, for severe knee deformity, varus or valgus, it's very difficult to be very accurate when you try to perform your total knee arthroplasty. And if you have bowing in the tibial bone or in the femoral bone, it's difficult to trust the intramedullary guide. So for the tibial, you can use extramedullary, and you can improve your tibial cut accuracy. But in the femoral side, it's very difficult. So you need to calculate before on the X-ray your deformity, and to try to calculate that preoperatively. So with mechanical ancillary, it's not easy with a severe deformity, mainly when the deformity is extra-articular and it's not just a wear. And so, of course, robotic is probably, or navigation is probably very helpful to be very accurate for this severe deformity.
And with respect to the choice of implants, would you advocate rather to go to a PS with what you learn now, or would you say, well, the PCL is sort of a medial stabilizer, I would like to go to a CR in the future? What's your point of view here? Or to a medial pivot knee? What do you think is the best implant to follow the IDs that you have given us?
So I don't have the answer now, and I'm not sure someone has the answer now. But for moderate knee deformity, CS or CR implant with PCL preservation is very interesting, and probably it's the PCL preservation. It's a very good tool to obtain a good stability of the knee and to restore a good kinematic of the knee. But when you have when you have severe deformity in varus or in valgus, I'm not convinced with the PCL preservation, because if your MCL is less efficient, if your lateral compartment or collateral ligament is less efficient, why the PCL can be very good and not stiff or not loose, or so you will trust your PCL but not your collateral ligament. So for severe knee deformity in varus or valgus, I'm quite afraid to do CS with PCL preservation sometimes, because I don't know the quality and the efficiency of the PCL.
I think it's also, Cecile, when the medial side opens up, it becomes more difficult to actually restore the joint line. I don't know if it's easier with robotic, but I think once it opens up on the medial side, it becomes much more tricky to restore the joint line, and therefore probably these are more deformed knees anyway. So I think it might even make sense to take the PCL as part of the deformity correction, because I think there are some studies when you take the PCL, actually you correct the valgus a little better than if you don't take it. Like for the more severe deformities, it might make some sense. I have a question for Sebastian. You know, like when you do CR knees in the valgus knee, what's your slope on the tibia? Because maybe the slope also in part can correct some of the deformity, isn't it?
No, yeah, true. The sagittal plane is also of importance, and we try to maintain some of the anatomy. So we do maintain some slope when we do CR. It also depends, of course, of the implant you're using. But we do maintain more slope in the tibia when we use CR than when we do PS, just because you cannot change so much the flexion gap. If you decrease the slope, you're going to tighten the flexion gap. and then it's difficult to keep the PCL. And that's something we learned from navigation and robotic. And if you try to change the slope too much, and then you realize you can't maintain the PCL because then you're too tight in flexion, then you have to release the PCL, so pretty much cut it, so it's not anymore a CR, knee. So yeah, the slope, and it's an interesting question because in the valgus knee, the slope is sometimes, if especially the severe ones, sometimes difficult to assess and to know exactly what's the native slope and how to maintain it. So it's difficult. I mean, to give a target, as well. But I love the passion around the discussion. By the way, it's super good to be challenged. When you get data and you try to create some recipe from the data, and I really I get to your point when you say, guys, are you saying you should keep 9 degrees of valgus? And I'm like, well, no, that's not what we want to say. So if this is the message, then we really have to rethink how we give the message. But yeah, I agree. I think valgus knees are different from varus knees, and I think we all agree on that. But we try to find a similar answer to, again, varus knees, but for valgus, and see what we should be aiming for. But I agree with you. The cosmetic part is something important, and it's difficult to say satisfaction and cosmetic are going together. We didn't ask them specifically about cosmetic, and that would be another interesting study, because that might be the answer. They're satisfied,
I did that,
but not happy with the shape.
We actually submitted that for for our closed meeting, like in September. So we asked valgus knees if they like straight knees and how they assess their knee right now. And it's quite fascinating that varus knees is slightly different. But when you look at what time point does the patient perceive their knee as straight, in a valgus knee, they only do that up to 2.6 degrees of valgus. After that, they know I'm knock-kneed. And if you ever talk to a patient that has a little bit knock-knee deformity, they almost always know that they're knock-kneed. And if you ask them what they desire to do, they want to have a straight knee. So it was interesting, if you talk to people that have relatively mild deformities, like 4 or 5 degrees, they always know that they have a knock knee. And it's very different when you look at varus knees. You can see a patient with a varus knee that has 5 degrees of deformity, and they will promise you that their knee is straight. And you measure in their 5 degrees of varus. So I do think in the human brain, there's a difference between perception of varus versus perception of valgus. We tolerate much less valgus before we recognize it as a deformity. And that's why I'm so interested that you kind of find satisfaction at 9 degrees, because I ask all my valgus knees, and very occasionally I find somebody that says, hey, I have a lot of valgus on the other side. I think I might want to keep it this way because I'm not having surgery on the other side. That is an argument very occasionally. I think 2 of our patients made that. But
Fritz, you may also consider the fact that maybe these 2 patients that had residual 9 degrees of valgus may have before a 19, so they gain 10 degrees and they're happy with it, because on the other side maybe they have like 6 or 7 degrees of valgus, so they have not straight but symmetric legs. So symmetric limbs, let's say. So it's also about, as you said, this is very important. It's also about the patient expectation and patient's perception of what's their limb alignment. I have a little question for the 3 of you. It's about the use of the type of constraint, because I'm having some satisfaction also in the valgus knee using a CR with a medial congruent liner and removing the PCL and reducing the slope. And in these patients, using the robot, I'm more able to balance the knee, and I'm able to use also in the valgus knee a medial congruent liner. What do you think about this choice?
what is the deformity level that you use it for? Is there like a limit, or you use it?
Yes, it's less than for sure less than 20. I would say less than 15. So it's still a mild valgus knee. I'm not talking about severe valgus knees where, and I'm still looking for a straight knee. I'm looking for a straight knee, and then I put a medial congruent liner. So my aim is still on the valgus side for a straight or a very mild valgus postoperative alignment.
Stefano, I think that's a very important point for that, because if you make a straight knee, you would probably be able to reproduce the very good results we all have had with medial pivoting knees. It's a very good design, works very well, and if you put it in neutral, all the biomechanical advantages of it will count. You know, like even if it's 2 degrees of valgus, I still think you can capitalize on the design. I don't think so if you put a knee in 6, 7, 8 degrees that you will see the same benefit, because biomechanically it would not make sense to capitalize on a medial pivoting knee in 7 degrees of valgus, I don't think.
It's an interesting remark you made, Stefano, and obviously as you use a medially stabilized knee, you gain a lot of AP stability, and I truly think that we orthopedic surgeons overrate alignment in its importance, and we underestimate the importance of stability for the patient. So when you give a patient a stable knee, I think you have a very high chance of seeing a happy patient. I wouldn't say regardless of the alignment, but I would like to put some relativity to the importance of alignment. I think stability is really the key, the number one key to a successful outcome. And it's clear that an immediately stabilized knee will help a lot in the AP plane. The downside of the PS knees in the AP plane is the clicking feeling that patients sometimes experience as they have some AP sliding. Obviously, they have a slightly higher flexion. That's the advantage of the PS. But your point is very well taken. I agree with you.
Stefano, do you think, I mean, the human knee has some laxity on the lateral side because to initiate rollback? I think there's some logic behind that the knee is a little bit more lax on the lateral side, probably to facilitate some rollback. Like when you look at the valgus knees, do you feel you have to keep a tiny bit laxity on the lateral side after your releases and everything you have done? Or do you put them in perfectly balanced? Like, I mean, I call it perfectly, but balanced, like where it's the same tightness on the medial and lateral side.
I have to say that if I'm using a CR with a medial congruent liner, I try to have the same balance on the medial and the lateral side also at 90 degrees. So the knee is balanced. When I look at the image you have in the robot, the blue line I have with the robot I use, but all the different images you can have on the robotic balance. I try to have both sides equally balanced.
Mm-hmm.
So
it's
this is
too, like a question for Sebastian too as well. Like, should we balance valgus knee different than we do like varus knee? Because varus knees we accept a little bit more play on the lateral side.
Of lateral laxity. True, totally
and
true.
I personally don't mind my valgus knee having a tiny bit more play on the lateral side as well, but I do think the philosophy might be slightly different for people on the call, isn't it?
The problem when you use a navigation or robotic, you realize when you try to correct, and I agree with Jan, stability is, for me, is if I have to choose between stability and alignment, I will always prioritize stability. The problem is when you tend to go close to neutral alignment, you realize you have to make a choice. Either you're going to accept some imbalance, or sometimes you have to maintain some of the deformity. And it's true for varus, it's true for valgus. And then the imbalance is not going to go in the direction of the lateral compartment. It's going to go in the direction of the medial compartment if you go close to neutral alignment. That's where we're going to be like, okay, let's keep 2 degrees because it's easier. It's going to be balanced the way I want it to be. And I don't have to do any releases. So it's 2, okay, why not 3? And then why not 4? And then that's where the discussion comes into more about then how do we make a recipe? How do we decide what is the limit? And then, for For varus, we have a lot of work because we have more patients, more numbers, so we have data. For valgus, I don't know. So for now, I tend to have the same aim regarding ligaments for my valgus knees as well, which is equal gaps in extension and slightly more lateral inflection, loose on the lateral side inflection to favorize rollback, as you said, and try to maintain optimal, let's say, flexion. But sometimes you just can't, achieve that because of the native laxity, which is very variable, as we all know. And if you want to aim for neutral alignment, you will have some slightly looser medial side, and that's where doing CR, and I agree again with Jan, to me makes sense because the PCL is making me more comfortable regarding the overall stability of the knee, even if I'm slightly loose on the medial side. So I'm more comfortable going for CR than PS in this situation, if I can manage friction gap and extension gap. That's the problem.
We have a couple of...
when you start to have numbers, and Fritz, I'm sure you would be so with all these numbers, and I know you do robotic, but when you have these numbers for every case and all the time, then suddenly you start to think and maybe overthink, and it's difficult to tell you, exactly the recipe again. I realize there are some situations when I have to make a compromise. I don't have the perfect answer, and the valgus knees are probably these situations more often than the varus knees.
Also because we're still putting, metal and plastic in the knee, so we need it's a joint that it's it's not a natural joint, so we need to make this new joint work. So sometimes it's difficult to apply, the concept of normal knee kinematics when we have to correct these imbalances. There are two questions coming from the floor, one from Matteo Ribroi and one from John Sullivan, but they are both about, normal alignment. And John Sullivan says that what is the definition of valgus knee, because normal knee has 6 degrees of valgus. And the other question is about CPAC, where we have some distribution of healthy and arthritic knees in varus and in valgus, and we think varus is more normal, but numbers are not with us. So a little comment from you about these questions, which are what is normal? And, we see much more varus than valgus knees, but normality, it's a normal distribution. So what do you think about this?
Stefano, there's a nice paper from Mathieu Olivier about on the osteotomy population. And I think they had over 700 patients. They looked at alignment and they found that the average alignment is 180 degrees, which is 179.5, whatever, is almost straight, plus minus 2 degrees. That covers the majority of knees that are out there. So, and I just, Sebastian, you were there, I gave a talk on normality and why the human knee is in neutral alignment. It's an evolutionary benefit of the human being to have a straight knee. We ended up like this. We even for a while overcorrected into a slight amount of valgus because we had weak knees. We didn't have an IT band to stabilize the side. And we only moved over time into accept a touch varus. It is an evolutionary advantage that we have now because we have a strong quad, we have a good abductor muscle, we have a good IT band. So normality is probably what is optimized for this kind of anatomic situation, which is probably somewhere close to straight. Because with the angles we have in the knee and where the weight of the body comes, we will always have an adductor moment on the knee. And I don't think that the evolution would favor 10 degrees of varus or 10 degrees of valgus because it makes, from the forces in the knee, not that much sense.
Fritz, I slightly disagree with you on this one, and the paper Johan and I wrote on the constitutional varus shows the bell curve distribution, and 95% of us, the healthy subjects that never suffered any type of knee trauma or operation, 95%, twice the standard deviation, is between 6 degrees of varus and 3 degrees of valgus. The mean value for the human population, the Caucasian population, is 1.3 varus. So there's a slight shift towards varus as a mean value. We also found that the boys are more in varus than the girls. So valgus is more of a female thing than a male thing. And finally, it was very much related to the sports participation. And that was an interesting finding because, as you mentioned, the adductor moment is giving a compression on the medial side of the knee. And if these children during their 12 to 16-year-old time do a lot of sports, the growth plate has to fight against these high loads. It's Volkmann's law. So they don't grow as fast on the medial side. They keep on growing on the lateral side and they end up in varus. That's why most good soccer players have varus knees. It's not because they needed to play soccer, it's because they played a lot of soccer as they were growing fast. So there is obviously a genetic thing, which is steered by evolution, but there's also the situation of what people are doing in real life. And I think we need to take both into account. But it's an interesting point. We should, next time I see you, we'll discuss about that. It's good. It's a great topic. I love it.
Yes, this could be a topic for a whole EKS hot topics, about the correct alignment, let's say, the distribution of alignments. So I think we're almost going to close this session. So any remarks from the three of you about?
I think there was a second question, no?
No, it was still about distribution. Probably here about CPAC and the fact that in CPAC the distribution we tend to think that varus is normal, but the CPAC is saying something different. But I think in the CPAC we have a lot of knees on the varus side more than on the valgus side. When you analyze the CPAC classification and the distribution, and we also know that there are mainly 5 or the 9 categories that are represented in the CPAC. So I would say that yes, if we look at this, Jan is winning with the varus alignment more than on the neutral alignment. But CPAC is also on a degenerative knee. So I think we're almost done. It's 2028, so we are about to close this EKS hot topics for tonight. I have to thank you very much. Thank the faculty for this fantastic discussion. Thank my co-moderator Sébastien for being with me, moderating these 3 great guys. And we will have the stop for the summer, and the next event is going to be in October the 7th. And it's going to be about operative OR efficiency, and the faculty will be disclosed very soon. So I will welcome you to come to the next hot topics in October. For the moment, I wish you a great summer and see you very soon with the next appointment. Thank you very much, all of you. Bye.
Thank you all. Thank you.
Bye-bye.
Well done. Thank you.
Thank you. Good discussion.